My name is Vartuhi Petrosyan. I am the Dean of the School of Public Health at the American University of Armenia, and I'm very happy to welcome all of you today. We have a very exciting event. The title is Global Health Symposium, Lessons from Oncology. And I would like to thank particularly two people with whom we developed this idea of having this symposium, Irini Albanti and Georg Tamamian. Thank you for the initial discussions and for the idea to host this very interesting event tonight. Oncology is one area that not only is a big burden for high-income countries, but it's becoming more and more important for low and middle-income countries, particularly in terms of access to quality care, psychosocial support. And there are only a few studies done, for example, in Armenia, and some of them have been done by the Master of Public Health students from our program as their thesis projects. And from those smaller scale projects, we know that this is a huge burden for our society. It puts a great financial burden on the families, and it's a big stress for the families of those patients. We have done some studies on, for example, breast cancer and the burden on the family, particularly looking at the financial burden. We have looked at the pediatric palliative care needs, in Armenia, and we know that there is tremendous amount of work to be done to bring evidence-based care to the people who live in low and middle-income countries. So I hope that today we will learn from the experience of, some of the very good, very reputable cancer centers from the US and have some lessons learned for Armenia and other low and middle income countries. I would like to thank our partners who helped to organize today's event, particularly the Dana-Farber Boston Children's Cancer and Blood Disorder Center, its global health initiatives, the University of Texas MD Anderson Cancer Center. I'm also thankful to the Armenian Association of Hematology and Oncology, City of Smile, and Idea Foundation. Without the efforts of these organizations, we would not be able to have this event today. So today we will have a series of presentations, and our audience can ask a few questions after each presentation, and then at the end we will have a panel discussion on how could we push forward this area for Armenia and other countries who are in similar situations. So I would like to present now the first speaker, who is Irini Albanti, and I would like to say a few words about our speakers. So Irini is the director of the Global Health Initiative at Dana-Farber's Boston Children's Cancer and Blood Disorder Center, as well as instructor of practice at Harvard Chan School of Public Health. She has more than 12 years of experience in hospital management and global health, and has been leading projects in Central and South America, the Middle East, Africa, the Caucasus region, Southeast Asia, and post-conflict countries such as Libya, South Sudan, and Iraq. Since early 2015, she has been heading the efforts to help pediatric oncology in Armenia. The floor is yours.
Hello everybody, and thank you. We'd like to thank the Dean for hosting us and all the support the last few months organizing this, and Georg Tamamian for his help again coordinating. So today I'm going to talk to you about developing a career in global health, no matter your specialty. So we're going to talk a little bit about global health, the several career paths that are available, how it is to manage a global health program, recruiting in global health, and how we can advance the global health profession. And I will start with questions, not because I know the answers, but because mostly it reflects what global health is and that it's really a developing field. Who runs global health and who decides what is global health, who is really funding all the global health programs around the world, what makes a global health expert? I mean, I'm from Greece, I work in Boston, I'm here in Armenia for a week. Does it make me a global health expert? I don't know. And then, who actually defines and decides what is global health? And we know there is some type of classification in low-income countries, high-income countries, developing countries, developed countries. I'm not sure I agree with this, because who makes this classification, who makes the decision? So all this shows what global health really is, that it's a multidisciplinary field. And as some of you are familiar with United Nations global goals, there are 17 goals. There is a global consensus about these goals, but again, it shows the nature of global health, and it's more like a puzzle. You can take one of these pieces and make the others better, or you can take one of it and really improve it and see what effect it has on the other system. For example, we talk about poverty, or we talk about reduction in health inequities. So about global health, it's definitely interdisciplinary and multidisciplinary. Here we have our colleagues from all the fields. It can be pharmacy, nursing, psychosocial. It's also about human rights. We cannot really talk about global health without addressing human rights. It's about equity and equality, and what's the difference between these two. We talk about the context and systems. We cannot really have it in a vacuum and say, we will treat malaria without seeing what's happening outside in the country. About data and technology, especially during the last few years. And last, ethics and social responsibility. When we work in a different country, we have a responsibility to the people of the country and how ethically really we conduct business. So why are people motivated to have a career in global health? So sometimes it's pure altruism, or we want to give back, or we want to be a change catalyst. We want to change something in our world, in our communities, in our countries. Sometimes people want to travel. We want to learn about new cultures, or develop expertise and niche in some areas. Who employs in the world? So it can be global organizations like WHO, UNICEF, or PAHO, governmental organizations, USAID, DFID, NGOs like Oxfam, Médecins Sans Frontières, or maybe Red Cross. It can be academic institutions like here, the School of Public Health, or Centers for Global Health, but we also see schools of medicine, even schools of business, being involved in global health. Hospitals like us or our colleagues from MD Anderson, consulting firms, big names like Deloitte or Boston Consulting Groups or John Snow International. It can be a government level, a Ministry of Health, International Affairs, or maybe the local level, or even embassies. Faith-based organizations like World Vision, even investment firms, especially in the United States, there are a lot of VC firms, venture capitals. Also the industry. I know that, for example, Pfizer has the Global Health Fellows Program, and this is something that in some countries, really, it's the industry that supports local philanthropy. But it's also a law firm, so you can have lawyers working on an environmental case. It can be a media company creating a documentary about children with cancer. It can be architect construction firms really building hospitals in different countries. And one of our professors, he said that every company has a public health footprint, but it's also a global health footprint. As we see here, we are people from all around the world coming together for one cause. So what are the career paths in global health? Sometimes it depends on the disease. Somebody can say that I only want to work in HIV, or for us, cancer, children with cancer. It can be about the topic, deciding that we want to tackle access to medicine, access to care, or health systems, or just disparities. Some of us decide to work in a specific geography. It can be Sub-Saharan Africa, for example, or the Middle East. Or we can decide our different roles, the clinician role, or deciding to do some research. On the management side, because I'm more on the management side, or on the policy, do we want to really impact how the government creates and forms policies? Or on the education and training side. Again, it can be a lawyer, it can be a journalist, a film producer, or a fundraiser. Without fundraising, global health really depends on fundraising. And I put donor here because we see recently this is a sensitive area that we can have big donors, we can have celebrities. Do they actually do global health work, and who decides that they are doing global health work? But they become so interested, and then they create their own healthcare system sometimes in small countries. So it's not really a professional global health person, but still it's a big donor with big money, and it creates some ethical decisions here. So from my perspective, I manage the Global Health Program at Dana-Farber in Boston Children's. We bring two institutions together. One is Dana-Farber and one is Boston Children's to do different programs. And mainly we do research, education, and capacity building. What it means for me, so a typical day can be drafting a budget for a new project. We can be writing a grant. We can be working with students like you that are doing their masters in public health. We can even writing content for websites so that, and now with social media or maybe working with Twitter and Facebook, we can even advise film producers on documentaries. We are also creating fundraising plans with our development group. We work with lawyers on creating contracts when we work with foundations or Ministry of Health. We advise our partners when they want to expand or create a new program. We develop monitoring and evaluation plans. We design interventions for a new program. When a partner wants to create a new facility, we can analyze how feasible this is. We also need to conduct research and really have evidence-based results behind what we're doing. And we also travel to sites. So when we are recruiting in global health, what do we look for? We look obviously for the technical job-specific skills. We would like for people to have some public health understanding and knowing the concept behind it. Also managing a project. When you are based in Boston and managing a program on the other side of the world, you need to be able to really coordinate and bring people together on an international level. It's important to have some previous work experience, and when you speak a foreign language, it's not only because it makes communication faster, it's also you come closer to a new culture and to people. More important though, I think it's motivation and motive, what makes people interested in global health and how, what brought them there. Their work ethic and how flexible they are. We know when we travel in different countries, sometimes we have a meeting on Monday, it's cancelled, it's on Tuesday. We have to be flexible, this is part of what we do. Or you decide to start a project in February, but because something is delayed, you start in August, and that's fine. This is part of doing global health work. And also being professional and respect for the local culture and the local need. And the program needs to come from the people who work there, not from us who are coming there. And last, it's excellence, and for us, excellence means wanting the same thing as we want for us in Boston, for our partners, not saying that it's good enough for them. It's good enough for us, it's good enough for everybody. What are the challenges though? Well, first it's funding, because global health is not really a revenue generating service line, so we depend on donations and funding around the world. It can be from private donors and institutions or just grant writing. Also the challenges are contextual, meaning political situation, economic situation, even natural disasters. And again, we plan a program or a new project, but something happens. It can be a conflict, it can be a hurricane, so we've seen that. Also, it's personal reasons, your families, and what you consider danger and what you consider the comfort level. This will make you a global health professional. Sometimes people ask us, well, why did you go there? Aren't you afraid? It depends what you mean by afraid and how you define danger. And last, for professional, it's about the training you have, and for us being in academic institutions, whether you have protected time to actually do the research and do the work. And how can we advance the global health profession, especially the young students starting their career? Again, for me, it's integrating business concepts and tools and trying to figure out an intervention that's really cost-effective, and you can measure the results. You can measure the impact that you have. Yes, maybe you have a donor that for some reason they want to fund a specific disease or a specific program, but it is really what the site needs, and it is something that we can measure in the end. And what's the evidence? What's the data behind that? And how can we find the data is we need to do research as we do in all other disciplines. And we need to use implementation science, and actually when we design all this, how do we implement and how do we measure this? We also need to share the knowledge among each other and to other sites. What may be working here in Armenia, we can see if it works next door or to another country in another region. And because we involve different countries, different cultures, and different systems, we try to make sure that it's transparent and equitable. Whatever we do, all the financial transactions, all the legal transactions that we do, that it's very transparent. We also want to make sure that we create sustainable programs. We don't go there just for one time and then we leave, unless it's a relief or it's a humanitarian type of project, that the program can be sustainable and that they can also replicate in another program. So maybe something working for children with cancer, but maybe it also works for another chronic disease. And going back to what we mentioned in the beginning, it needs to be need-based, based on the country, not only on the donor. And last, this is a slide from Boston University. It shows again the nature of global health, that it is a global community, but everything is interconnected. We cannot do it on our own, and we cannot do it just on one perspective. We need to combine science, and humanity, and transparency, and equity, and collaborate with each other. So last, if you want to have a career in global health, I think the question is why really you want to do that, is how you want to do that by building your skills, your technical skills, but also your professional skills, and then how well depends on the impact you will have, how you're going to measure it, and the integrity you bring behind you. Thank you.
Any questions? We have microphones for our participants. Please.
Hi. Thank you for the presentation. I'm Damodaran, doing MPH second year. As a part of my my thesis topic is preventing cervical cancer in one of the rural districts of India. So I'm doing master, like a project implementation grant proposal. So I'm almost done with all the parts. My doubt is, after completing the thesis, after my graduation, so what is next? How can I move forward with this grant proposal? What is next? I don't know how to proceed forward. Say, for example, it is a huge project. It is going to be implemented in around 300 villages in one of the districts in India. So, right now I don't know how to move forward. Just based on your experience, just give me a few suggestions.
So you have the plan ready, right?
Yes, of course.
So do you have any connections with local foundations, something that they are already doing something similar?
No, so far no, but I did my summer internship in India. They were working in the same project, but they were not doing what I am doing. So they were doing the traditional methods, like preventing cervical cancer with traditional methods. I am using the new rapid HPV DNA test, which is proved as cost effective. So right now in Tamil Nadu, particularly in our state, the test is not yet available. It is only available in Delhi, Mumbai, in some of the parts of India. So I don't know how to move forward. So,
well, you can start with community-based programs, or if
Yes.
there is a community clinic that maybe provides family planning, or maybe provides on the community level, or if there is an established network of community health workers, or on the ministry level, or if there is a foundation that works around women's health in general, or if there is an existing program that you can in a way piggyback without having to create the infrastructure yourself. So, and you're coming there with something ready, so they don't need to think about it. So you give them the plan on how to do it, and then you integrate your plan within their own services.
Okay.
So that could be an option.
Thank you.
Okay, thank you, Irini, very much. We will move to the next presentation. So the next topic is cooperating globally to conquer cancer. And our speaker is Karen Francis, who is the project director, Global Academic Programs at the University of Texas, MD Anderson Cancer Center. She is responsible for initiating, evaluating, developing, and implementing multiple international partnerships, projects, and programs. She was instrumental in the development of the first international affiliation of the center in Madrid, Spain, and other sister institution affiliations. She evaluated, organized, managed, and directed other international academic collaboratives, projects, and programs with sister institutions and other global partners. She is responsible for a large portfolio of global academic partnerships in such countries as Brazil, Chile, India, Peru, and Turkey. She is responsible for the coordination of the annual Global Academic Programs Conference, which includes attendees from some 20 countries and more than 30 international academic, research, and clinical institutions. Please.
Thank you very much. Thank you very much, and welcome everyone. I would like to say thanks for this opportunity to be here in Armenia. It's my first visit. I hope it's not my last visit, and I'd like to say special thanks to Gevorg because he had the foresight to connect with our faculty and our team at MD Anderson and make this all happen, and also with the people at the Boston Children's Hospital and Dana-Farber. So thank you very much for this opportunity. Okay, so today I'm going to speak about MD Anderson's global academic programs. And global academic programs, we call it the GAP program, GAP as the acronym. This is the department at MD Anderson that evaluates and initiates and creates all our international partnerships. These are research and academic partnerships based on what our faculty are interested in. You know, we have many faculty at MD Anderson and many from many countries around the world and many from America also, but they have interest with other places and they want to sort of work with other countries and other institutions around the world in order to advance some of their knowledge of the various cancers that we face in these days. So I'll go through what we do. The mission of MD Anderson is to cure cancer, not just in Texas, Houston, Texas, the United States, but also the world. So this is a way that we are advancing this mission throughout the world. The GAP program consists of a network of some 32 sister institutions in 23 countries, including 5 consortia. The consortia are actually multiple institutions within a city or within a country. And again, I said earlier, this is to support the work of the physicians and researchers at our hospital. So, meet our sister institutions. They range from all kinds of institutions, national, regional cancer centers, academic hospitals, private hospitals, university cancer centers, private non-profit academic cancer hospitals, and private non-profit academic hospitals with strong cancer programs. They're listed alphabetically there. Our latest partner is the Italian consortium. This was recently signed just last month. This consists of about 14 different institutions in Italy, mainly the regional cancer centers and other universities and hospitals within Italy. So that's our program. Those are sister institutions. So this is MD Anderson for those of you who have not yet been to Houston, Texas. This is the Texas Medical Center. All the buildings in front are really MD Anderson, and that's downtown Houston in the background. So why associate with MD Anderson? This is some of the facts. MD Anderson is part of the Texas Medical Center, which is a very large medical center. Some people say it's the largest in the world. We have 9 academic institutions within the Texas Medical Center. 6 are healthcare institutions. MD Anderson is one of them. and the University of Texas Health Science Center at Houston is the second one within Houston. All the others are in different cities, Dallas, Galveston, different cities of Houston, and most of them are university settings, like University of Texas at Austin, University of Texas at San Antonio, University of Texas in Dallas, etc. But they're all these academic institutions. So MD Anderson is part of the Texas Medical Center. You can see we have other academic institutions in there, including the Baylor College of Medicine, Rice University. This Texas Medical Center is huge, has over 100,000 employees, 7,000 beds. You know, we have so many visitors per year. And MD Anderson actually is not only the largest entity, but it employs the largest number of people for an institution within the Texas Medical Center. Again, here's our mission. We're mission driven. These are the 4 mission areas that we try to incorporate into all our activities. Patient care obviously is the first. Research, prevention, and education. Just to give you a little background or some important facts, information on patient care, this is one of a data sheet with our statistics, our clinical activity, hospital admissions, number of patients, number of outpatients, treatments. I don't need to really go down the list, surgery hours, etc. And you can see how most of these have increased over the years. So, you know, we're seeing more and more patients as the years go by. Research, we're heavily invested in research because we feel that we cannot be the top cancer center that we are without research. So our research funding comes from many different areas. As a matter of fact, I believe we get the largest amount of research from the National Cancer Center in the United States, comes to MD Anderson, but we also get lots of funding from philanthropy, from different funding agencies, grants, etc., and you can see those numbers there. So research is very important in the mission to eliminate cancer. A few years ago, we got a new president 4 years ago, almost 5 years ago now, and he implemented what is called the Moonshot programs. And this is a program to really expedite and accelerate the research in certain cancers because we have the ability and the know-how and to make these discoveries into clinical advances. So these are the areas of the moonshots. A lot of money is being invested in Houston in these areas. That's not to say they're not research in other areas, but these are the moonshot cancer areas. Education and prevention, again, is one of the keystones of our mission. Education, many people come to MD Anderson. They're residents and fellows that rotate through MD Anderson. They're trainees, nursing trainees, students. You know, there's a School of Public Health in the medical center. So MD Anderson is a teaching and research institution also for other medical schools in the medical center. So, and many international visitors, surgeons, oncologists come for periods of training throughout their training program. Prevention is really something that we have increased lately, because without prevention we feel that prevention is very important. In many countries around the world do not have prevention programs, but prevention and screening is important. Many people ask me, can I come to MD Anderson? Is it only for people with cancer? Well, it's really not only for people with cancer. I actually am a patient at MD Anderson. I get my annual screenings there. So I go to MD Anderson once a year. There's a special prevention built in. There's a special prevention department. So it's open for anyone who is willing to come to MD Anderson. Our departments are, this is the structure of MD Anderson. We have clinical divisions, which are the bigger, higher divisions within MD Anderson. We have, as you can see, we have many different clinical divisions, and then we have basic science departments. And, you know, varying from basic research to translational research to clinical research. But the care at MD Anderson and the research is always multidisciplinary care and research driven. These are the centers. Part of the multidisciplinary care at MD Anderson is focused in a center. So when you come to MD Anderson as a patient, you will see the medical oncologist, the surgeon, the radiation oncologist, all in the same center. They come to you, you go to one place, and they see you in the various centers there. So our sister institution program started about 12 years ago, more or less. It's an academic partnership for our physicians, and to be a sister institution, we must have broad engagement across multiple specialty areas, and this is again driven by our faculty. We support what our faculty wants. So just to tell you a bit about it, it takes 1 to 2, maybe 3 years to build, but one of the key things to be a sister institution partner is that you must have a research project existing before we can even consider that you will be a partner. Simply because we feel that if we don't have our faculty involved and engaged in the work that we want to do globally, it will not happen. We cannot just go out and sign a contract with a hospital in any country simply because that's what we want to do. We have to make sure that our faculty are engaged and really want to focus and make the relationship happen. So it's a process, it's visits, reciprocal visits. We look at the infrastructure, the clinical activity, the research, everything related to the institution we're about to partner with. And then we have to make a presentation we have an international advisory board that will review the proposal and then make a decision why we should move forward with this program or not. And there are things that we look at when we analyze and evaluate different institutions. Is it a regional cancer center? What's the status in your country? Do you have a strategic plan? Is there funding? Is there infrastructure? Things like that. But it's a process, and so over the years we've developed also other partnerships that are not necessarily as broad-based as sister institutions. They are more memorandum of understanding agreements that are based on one area, 2 areas, or the interest to develop some type of partnership. Okay, now this is our GAP activities, GAP Global Academic Program activities, or research activities. About 4 or 5 years ago, we started a Sister Institution Network Fund. The institution agreed to give us a few millions of dollars to invest in research projects. But one of the key elements is that we must have an investigator from MD Anderson and a partner from around the world. And this gives you an idea of where our projects are in the world at the moment, and the amount of money we've invested so far is about $10 million. Additionally, our partners have also invested about the same amount, so it's about a 1-to-1 equivalent as far as the research activity. So the monies do not travel. When a grant gets funded, the monies remain in Houston. The other partner in another country has to provide some sort of funding for his or her research work. So we collaborate globally and fund locally. And that's just to show you some of the papers that have resulted and grants that have resulted from these Sister Institution Network Fund. And they vary in many kinds of cancers, cervix, breast. They cover all the ranges of cancers. There's nothing that's not included in the research projects. Here again, just another scope of the Sister Institution Network Fund that we do. And of course, it's all related to cancer in some form or fashion. And since since we started this Sister Institution Network funding program, we can see that our papers between our faculty and our partners around the world have increased. You can see when we started it, it has constantly increased. The last 2 years, probably not as much, but the papers have gone up because people are focused on the work that's being done between the institutions. And the chances of being funded by this SINF grant funding, the more partners you have in your proposal, the higher score I believe you will get from the scientific advisory board that reviews the projects. This is also this is an NCI initiative that we've also participated in. We've shared our programs with them, and this is public. It's on their website. But we are a part of this NCI initiative with this Global Cancer Collaboration Map. And some of our activities, some of the research projects that we do all kinds of projects. You know, there's surgical trials, there interventional therapeutic agent trials, we have palliative care trials, cancer control studies, and this shows you many of the countries that are involved in these trials. As you can see, they're not just in Asia, they're in South America, they're in Europe, and many of our partners over the years have come together and they've met in Houston or they've met at one of our conferences, and they have realized they have a similar interest and activities, and so they've begun working together. And again, just more of our GAP activities. This is focused on prevention. We've done 2 agreements with the governments in Colombia and in Mexico with the National Cancer Center in Mexico to eliminate tobacco use in their countries. And this is something that's relatively easy to do if the government gets involved, if you educate the students in schools. This is a simple project that really has taken off in many countries, and it doesn't cost a lot. And then our big signature activity for the global academic programs is our annual conference. For the first 6-7 years, we always had our conference in Houston, Texas. All our partners came to Houston. We had the conference. We talked about the project. There were presentations, there were discussions, and collaborative discussions. And at some point, the partner said, well, why don't we have the conference in a different country, somewhere else around the world, hosted by someone? And we said, okay, we'll think about it. Yes, and we did think about it. We started in 2012. Norway was the first country to host the conference away outside of Houston, and it was such a success that we decided, this is interesting, let's do this every 2 years. So now every 2 years, the conference is held in a different country, and then every odd year, it's back in Houston. We just finished our last conference in Brazil. Our 3 partners in Brazil were the hosts for the conference, and you can see the participation there. We had about 788 people participating in this conference in Brazil, which took place in April last month. Next year in Houston, it's going to be during the month of May, and I'd like to take this opportunity to invite all of you in the audience and others that are not here to come to Houston, visit Houston, meet our partners, participate in the conference, and see what it's all about. Maybe you can get some ideas of things, projects, or things you can do for yourself or in Armenia or elsewhere. Some other activities we do as partners, whether you're a sister institution or not, we organize joint conferences, we do video conferences with case discussions with our physicians. Cases are sent, we confirm the physicians who will participate. They discuss with our physicians specific cases of interest. And again, we host visitors who want to come, whether it's a week, a month, 2 months. It depends on what your interests are and how long you are able to stay there and what is it that you want to focus on. And in the last few years, we started an Africa initiative, which has taken off really well. This Africa initiative, we're not alone in this. We decided that many other organizations, institutions have been involved with Africa before we got there. So we've partnered with them, and you can see some of the names there: the UICC, Union for International Cancer Control, the National Breast Cancer Foundation, the CDC, the National Cancer Institute. So all these institutions and organizations are working with us in our programs in Africa. And again, we've done on-site workshops. People have come to Houston for observerships, fellowships, and the trainer program exists. And specifically, I want to point out that the names listed at the bottom of the slide there are our Brazilian partners. So they have really been the force behind our partnerships in the Portuguese-speaking countries in Africa. And they have done many visits, many workshops, and so this has been really one of the strong points of this Africa initiative. Just to show you where we are there in Africa, these are emerging relationships, and I said we have the workshops ongoing, and we do telementoring by the ECHO program. The ECHO program is an external community healthcare outreach program which got started in New Mexico. It actually also occurs in Texas, in the rural areas from MD Anderson, and we've taken this program also to Africa. So there are many sessions of the telementoring that occur on a regular basis from Houston with our African partners. And this shows you some of the areas we're focused on. Breast and cervical cancer are two of the prominent areas that we focus on in Africa. Obviously, the needs in Africa are quite different than the needs in some of our other partners around the world, in Europe, in Asia. So, we've taken a different route in working in Africa as we develop our global partnership. And again, these are the dates for a conference next year in Houston, Texas. So mark it on your calendar. You can go to our website also. We hope many of you from Armenia will be able to join us in Texas. And then just last month, we have already decided in 2 years from now where we're going to be. This was announced in Brazil. We're going to be at the Karolinska Institute in Stockholm, and the dates have already been set also. So again, this may be a little bit closer for you to come to, but you should also come to Houston at some point in time. So with that, I just want to say thank you again, and it's been a pleasure to be here and to speak with you. And if there are any questions, I'm happy to answer them, and I'll be around for the next few days. So just come up and speak with me, and thank you very much.
Hi everyone, thank you so much for a very nice presentation. Thank you so much for the event. My name is Ani Haykuni. I'm Armenian. I'm fighting cancer since last year, since July of 2015. It's a highly aggressive type of breast cancer. And a person who has gone and still going through all the difficult time, the treatment especially, the chemotherapy, surgeries, etc. It's really interesting for me. You said that your center does research, right? It's one of the critical points for the center, for you. And I know that the treatment that we get and I get has to be confirmed through the protocols, international protocols, right? So when you do research and you have results, let's say positive results, progress, can you apply them immediately, or you have to wait for some procedure to go, and so the protocols, it can be confirmed in the protocols and then you can apply, or you still use the results, you apply the results of your research like at the local level, like through trials or so. So that's my first question, and also I'm very interested whether the center usually publishing the results of this research, And the short one, the next one is or maybe you can go with the first question and then.
Yes, no, there is a process before we are able to use any drugs or any protocol that's a research protocol. There's a protocol for that, and there's a process that you have to go through with the regulations and the governmental process to get this all approved. You know, we have some of our physicians here in the audience who are more involved with clinical trials and things like that, and maybe they may want to comment. Any one of you would like to comment about the process at MD Anderson? But that's the answer to the first question. And yes, they are published eventually. They're presented in papers at big meetings like ASCO or elsewhere. These results are published. But is there anyone in the audience? Dr. Bedikian.
Clinical trials include new drugs that are not available. Clinical trials that are done in MD Anderson, they are the first time done in human beings with new drugs that are not commercially available. By regulation, those drugs could not be given to any patient outside the protocol. Results are evaluated at the end of the trial. They are reviewed by the pharmaceutical company and the FDA. And if the results show significant improvement in terms of benefit, whether it's survival or otherwise, FDA decides to approve the drug for commercial use. And then, based on the review of the FDA, the pharmaceutical company decides to market the drug. And then it will be available in many of the Western countries first and then other countries later on. There is a time period to do a good clinical trial until the FDA evaluates and approves. It has to pass through a phase 1 study for safety and efficacy, and then a comparative study to show that it's better than available drug or safer than available drugs. That trial has to include large number of patients with 2 arms to compare the benefits and side effects. Usually it takes about 2 years to complete the study, and then 1 year to analyze, and then publish the results. The clinical trials, after they have been completed and they have been reviewed by the FDA, usually takes 6 months for the pharmaceutical company to market the drug. And as I said, usually these pharmaceutical companies, they have branches in various big countries, most of them in the Western world, and there they start marketing the drug. Now, it will take a longer time for the drug to be available in other smaller countries because they don't have centers to produce the drug. Okay?
Okay, so generally saying it takes about like from 4 to 5 years in order to. Okay.
Yes, from the first testing of the drug until you see it marketed. Another important thing is that out of 10 different drugs evaluated, in general, 2 or 3 of them will be better than existing drug that eventually will be marketed. So not all the trials will be positive.
I see. Thank you. And if you let me just the third and very short question, you said about the cooperation, and if I'm not mistaken, you also said the organization that the center will be willing or will be considering cooperation with has to have a component of research, right? Or the faculty of the center has to be able to be involved in any of the project or the activity of the second organization. Let's say, for example, if there is one organization in Armenia that is really interested in cooperation with your center, do they have to be a research organization? Do they have to be, it has to be like a hospital, or could you please just provide a little bit more details on what it has to be?
No, it does not have to be a hospital. It can also be an organization. We will be signing an agreement here with the Armenian Hematology Association tomorrow for training and education in Houston. So the partnerships and the relationships are very significantly amongst each other, but the sister institution partnerships have a specific criteria that have to be met before we become a sister institution. But we have many other cooperative agreements with other agencies and other hospitals around the world. Any more questions? Thank you.
Thank you. I would like to thank Irini and Karen for emphasizing the importance of partnership for this type of projects and research projects. And please know that the AUA School of Public Health has very strong expertise in research. And I hope that this is a beginning of a partnership that could be used to bring some of the, advances in cancer care to Armenia through partnerships. Thank you. So our next speaker is Jorge Fernandez. He's going to talk about creating psychosocial programs globally. And this is one aspect that we are almost missing entirely in Armenia. There is a big gap, and I hope that some of the lessons that you will share with us will be applicable for Armenia. Thank you. And I would like, of course, to say a few words about the speaker. So Jorge Fernandez is a senior member of the Division of Pediatric Psychosocial Oncology and member of the Global Health Initiative at Dana-Farber Boston Children's Cancer and Blood Disorder Center. He began working in pediatric oncology in 1999. His international experience in pediatric psychosocial oncology includes clinical consultation, assessment, program development, staff support, abandonment reduction, and patient communication and education with partner sites in Asia, South America, and the Caribbean.
Right. Well, good afternoon. Thank you very much. It's a pleasure to be here. I'm going to talk to you today about the creation of psychosocial programs globally, but more specifically, the role of psychosocial care in international partnerships. Now, because of time limitations, I will not go into great detail about the particulars of psychosocial oncology. And keep in mind that I work in pediatrics, and so while many of these things are applicable in medical and adult oncology, I'm essentially talking about pediatric examples and pediatric oncology. So, the first thing I want to start with is this quote from an oncologist and teacher and writer, Rachel Naomi Remen, whose books you may know, which goes to the issue of setting context around what we do. And that is to keep in mind that patients and families, and when I say patients in pediatrics, and I'll try to just use patients and not both, I'm referring to patients and their families. It really is that kind of an idea. Do not come to us because of psychological problems. So it's not that they're needing this, even though there are many stressors involved. What they're facing is just a very, very challenging life situation and need to sort of mobilize their resources, internal and external resources, in order to face those challenges, and very importantly, like the end of this very much, is to live well despite the experience of cancer. So continuing with this idea of the context in which we work. So if the patients are not here for mental health reasons, then what are we sort of doing? What's the role of psychosocial providers? And I want to say that when I talk about psychosocial care, there's sort of the formal part of it where psychologists, social workers, psychiatrists, child life specialists, play therapists, the gamut of disciplines that are involved are providing some of the most of the technical kind of aspects of it. But psychosocial care really covers the entire sort of experience from the team's perspective. So we want to support the larger medical, and that's really what we're there for. And obviously the goal of achieving good outcomes and as positive an experience as possible for the patients. And in that, what we're doing, again, to emphasize, is helping to address these life challenges to sort of enhance coping and well-being. So, shifting gears just a little bit to sort of some information about the burden of pediatric cancer worldwide. There are roughly, or about 200,000 new cases of childhood cancer reported, diagnosed in the world annually. Of those, about 80% occur in low and middle income countries. Well, a huge number of them. But the survival rate in those, the sort of the 5-year event-free survival rate, is about 20%, so across all diagnoses. In high-income countries, it's the exact opposite. Right? So about 20% of the cases are reported, and of those, so maybe 40,000 cases, 80% are cured. This, of course, is a huge disparity, and as was mentioned earlier by really, frankly, that's sort of a human rights issue in my opinion, and of course the reason why we're in this work in the first place. So to be more specific about why this is the case, in low-income countries, the challenges are some of the ones you see here on the left-hand side. So late presentation, underdiagnosis, abandonment. I should say abandonment is a term that I'll go back to, and it's certainly a very big issue in terms of psychosocial involvement, but it's not a term that I particularly like, and I don't think it's accurate because what it really represents are many, many things, but most of all, it's lack of access for patients. But in the literature, that's the term that's used, and we can use it. Other issues, malnutrition, other comorbidities, suboptimal support, and palliative care. I should say, palliative care is an especially important issue, as is probably obvious when you have these mortality rates that are so high. The level of suffering is also high, and it's important to think about pain control and palliative care for those large numbers of patients. And the response, sort of generally, in terms of international partnerships, or the goals are things like building capacity, incorporating research, and implementing sort of intensity graduated therapies. Now, in this slide, what I've got are places where psychosocial intervention is important in the development of pediatric cancer programs or relationships between a high-income country and a low or middle-income country. And you can see as you come across the levels, a given country or center can find itself, in any of these first, second, or third levels, typically 1 or 2. And one wants to start by focusing on the things that that can be done. Early diagnosis, public awareness. Again, palliative care is something that we emphasize, again, because of the high mortality rates. And there's a role for psychosocial providers, I would say a sort of a fundamental role, but that may seem sort of a little bit controversial if one says, okay, well, if we have this sort of degree of resource sort of limitation, and we have this kind of crisis proportion of mortality, how are we going to put our resources into sort of therapy or finding a psychologist? That's not really the idea initially, and I'll get into this more so. I'm a social worker by training, and certainly in my discipline, issues of social justice and of affecting the sort of the context and the world that the patient or client lives in is a very sort of fundamental part of the mission. So there's a role in all of these things, and I would say one that that's not only hopefully helpful to the patients, but that can also be supportive of our medical and nursing colleagues. Now, taking a little look sort of at the history of some of this, again, in pediatrics, pardon me, the model that's been used, not exclusively, but certainly a very commonly used model, is the twinning model. And what that involves, and you can see some sites here, it's a high-income country sort of established center, like Anderson or like ourselves, partnering with a center in a low or middle-income country, typically a public center, and by the way, by invitation of the host country. So it's not as though we go about sort of saying, okay, you need help, or do you want our help? It really starts with a relationship, typically one oncologist with another, and kind of goes from there. and very importantly, a local foundation to support some of the sort of the goals that are typically involved. Again, the benefits of international collaboration, I think this is very important. Someone sort of unfamiliar with this might say, well, the high-income country is going to provide all these benefits for the lower-income country, and hopefully there are some benefits, but it's really a reciprocal and mutual kind of collaboration where higher-income countries, centers, and providers gain a lot, learn a lot from these exchanges. And you can see some of this in the slide from World Child Cancer, which is Foundation of London that we've worked with. You can see sort of some of the things that are benefiting either group, and all of these, or most of these, are applicable to psychosocial interventions or providers as well. So, in trying to sum up a little bit, when we focus on the sort of the psychosocial dimension or area that we can sort of impact upon, we look, or I think, looking at these issues of limited access and low adherence, which account for a lot of the sort of the reason why the rates of survival are so much different in low and middle income countries. I think you can divide those up into sort of two areas. So you have, on the one side, concrete needs. We know that things like transportation, housing, childcare, loss of wages, things like that, are very, very significant barriers for many, many people that keeps them from being able to either start or continue and finish treatment. We also know that many folks, and here in the abandonment literature you'll see this, both the concrete needs, but also issues of trust and understanding of treatment and illness. It's a big part, and certainly in my experience, published a study, a project we did in Bogota, in Colombia, and while transportation was the first reason that folks who abandoned decided for doing so, the second one was lack of or limited understanding of diagnosis and treatment, and certainly trust and a complicated medical system that one needs to help to navigate. And so, what is the sort of the intervention or the response that we can give to this? So again, I won't go into